This is the PANRE review. My goal with this is to be as short, simple, and practical as possible. So with that, we'll go on to our first disease. What is the number one cause of death in America? What is the number one cause of death in America? The number one cause of death is related to a disease process, and we refer to this as coronary artery disease. The definition of coronary artery disease is what? Coronary artery disease is the narrowing of the vessels by 50 to 70%. So coronary artery disease is kind of an umbrella term, and there will be other things that fit underneath that, because the narrowing of the vessels by 50 to 70% is going to be related to disease processes such as hypercholesterolemia, where you're having a buildup of cholesterol in the vessels of the heart. The signs and symptoms that this is going on will be symptoms such as what? So if someone has narrowing of the vessels, what signs and symptoms would you expect to see? The signs and symptoms could include things such as chest pain, angina, shortness of breath, weakness, sweating, claudication, which claudication is going to be a narrowing of the vessels that's occurring not necessarily in the cardiac vessels, but could be something like in the iliac artery or other arteries in the periphery that's going to cause pain. Leg swelling, syncope, dizziness, and rales. How can we calculate the risk? Since coronary artery disease is the number one cause of death in America, what specific tool do we use to assess the risk? According to the AHA-ACC guidelines, the Framingham can be used to analyze the risk that someone has related to their coronary artery disease. So the Framingham calculator. Framingham calculator will be looking at someone's age, their LDL cholesterol, their blood pressure, history of smoking, and history of diabetes, which gives you your main risk factors for coronary artery disease. So I'll ask that again. What are the main risk factors for coronary artery disease? Someone's age, their cholesterol levels, their blood pressure, whether or not they're smoking, and diabetes. How do we treat coronary artery disease? How would you treat coronary artery disease? Because this is more of a process than a specific thing, the best thing that we can do is modify risk factors. We can modify risk factors such as cholesterol and hypertension through lifestyle changes, dietary changes, lowering the amount of fatty foods and foods that are high in cholesterol. Exercise can also help. We can get individuals to stop smoking, and we can stabilize someone's diabetes. Now we'll cover some of the treatments for coronary artery disease when we look at some of the specific components of them. For example, what do you do to treat angina, the chest pain associated with coronary artery disease? We treat the symptoms of it with nitrates. We can treat with beta blockers to adjust blood pressure and lower blood pressure, as well as ACEs and ARBs. What can we do to treat the high cholesterol? The most commonly prescribed medication would be statins to do that. We can also use things such as calcium channel blockers. And that is coronary artery disease. One of the things that primarily influences coronary artery disease is essential hypertension. Essential hypertension is contrasted to secondary hypertension in that secondary hypertension is being caused by some other disease process. Generally, essential hypertension is going to be related to genetics, things such as their weight, their diet, how much they exercise, and the overall health of their heart. How many people have been diagnosed with essential hypertension? About 86 million adults. The major risk factors associated with hypertension would be what? Meaning, if you have high blood pressure, you are at risk for what specific diseases or conditions? Those conditions include things such as myocardial infarction, stroke, kidney disease, and vascular disease. What is the diagnosis of essential hypertension? The diagnosis of essential hypertension comes with a blood pressure of what? 140/90. Now they break this into stages. Stage 1 of essential hypertension is what? Systolic 140/159/90 to 99. Stage 2 is 160/100, 160 to about 179/100. And stage 3 would be 180 or higher over 110. What is the worst case scenario with blood pressure? If the blood pressure gets too high, you can go into what is called a hypertensive emergency. The literature on this has been confusing as I went through up to date. I was originally taught about hypertensive urgency and emergency. For the purposes of the PANRE, they only list hypertensive emergency. And a hypertensive emergency would occur if the diastolic reaches what? Hypertensive emergency is when one has an acute diastolic blood pressure of greater than 120 millimeters of mercury. On the systolic, however, what is the systolic number that would be indicative of a hypertensive emergency? A systolic greater than 220 millimeters of mercury. The risks of hypertensive emergency, and this will be similar to the risks. We looked at hypertension originally as this is a long-standing, years after years of high blood pressure puts one at risk for, if you recall, myocardial infarction, stroke, kidney disease, and vascular disease. In an emergent sense, when the blood pressure goes too high, you are at risk for certain things. So if your blood pressure was to reach greater than 220 systolic over 120 diastolic, you would be at risk for what things? So think for a second. Pulmonary edema, CHF, hypertensive encephalopathy. This can result in an intracranial hemorrhage, end organ failure, or a subarachnoid hemorrhage. This makes sense because if the pressure is too high, you're going to start to see vessels burst. The bursting of the vessels will result in pulmonary edema, some cardiac heart failure. You'll also see this happening at the level of the brain. If those vessels start to break and hemorrhage, you'll get bleeding into the brain, and these are very serious and life-threatening. So the numbers again, systolic greater than 220, diastolic greater than 120. One of the signs that you can see when someone is in a hypertensive emergency that would be indicative of some of these problems would be papilledema. Papilledema is hard to see when you're using your natural instrument. I think nowadays they have more advanced instrumentation that you can look at the back of the retina to identify the papilledema. How do we treat hypertensive emergency? The treatment is to slowly lower the blood pressure. You lower it by about 25% in the first hour, and the goal is in the second hour to get around 160/100. The treatment, you can use antihypertensives such as labetalol. Labetalol is a beta blocker, and you would administer something around 10 to 20 milligrams bolus. Again, you want to slowly lower the blood pressure. You don't want to do this too rapidly. Something that also we should associate and remember at this time when we're talking about hypertensive emergencies is what is the name of a hypertensive emergency in pregnancy? A hypertensive emergency in pregnancy is eclampsia. You can also have preeclampsia, and these are hypertensive emergencies in pregnancy. The treatment will not be with labetalol. Instead, how do you treat a hypertensive emergency such as eclampsia in pregnancy? The treatment would be hydralazine. Going back, though, to hypertension, how do we treat hypertension? The general hypertension, whether it's stage 1, 2, or 3. We treat with, the treatment will depend. So there's different guidelines. You could go online and look up the guidelines. The most standard ones you can use would be something like an ACE or an ARB. the problem associated with ACEs is what? ACEs have a few things. ACEs will cause cough. ARBs have less cough, and I think ARBs have come down in price so that they can be used a little bit more readily. Some of your choice and selection of antihypertensive medications would be in looking at some of their background. For example, someone who has a history of heart failure, what kind of antihypertensive medications would you use for them? You would use a diuretic, a beta blocker, an ACE, and then an ARB. So diuretic first, beta blocker, ACE, and ARB. Post myocardial infarction, we use a beta blocker and an ACE. In diabetes, it was listed an ACE or an ARB, and then you can use a calcium channel blocker or a thiazide diuretic. For someone with chronic kidney disease, an ACE or an ARB, that like lisinopril or losartan. Second line would be a calcium channel blocker or a thiazide. It was also listed when I was doing the research through eMedicine that people with an African ancestry, you may want to think of a calcium channel blocker or a thiazide initially. In my own clinical practice back in the day, most people I saw were on ACEs and ARBs and beta blockers. Those tend to be the most common. So can you name a few ACEs and ARBs? You have lisinopril would be the most common ACE. Losartan would be an example of an ARB. As far as beta blockers go, the most commonly used ones are metoprolol and propranolol. There are more and more medications that come out that have extended release that make those a little bit easier. One of the little buzzwords to associate with beta blockers is who would you try to avoid using beta blockers in, or who would you show caution using beta blockers in? That would be a patient with asthma. Secondary hypertension. Secondary hypertension is hypertension that is caused by another medical condition. How do we treat it? Well, because it is caused by another medical condition, the treatment of secondary hypertension is going to be to treat the underlying cause. The diagnosis of secondary hypertension is made when? Or when would you suspect secondary hypertension? You would suspect secondary hypertension if someone has very high blood pressure, perhaps it is around that 180 over 110. You would suspect secondary hypertension if the onset was sudden. Perhaps if somebody is not obese, they don't have the typical look of someone with high blood pressure. So a thin person, someone who just all of a sudden develops very high blood pressure, the blood pressure is very high, and the other would be that they are unresponsive to standard medications. What are some of the causes of secondary hypertension? So this is an opportunity for you to try and form a list. What are some of the causes, things that would cause secondary hypertension? Diabetes, kidney damage. When someone's kidneys are damaged, it's going to affect the important chemicals that help regulate blood pressure, which is why some of the blood pressure medications target some of these pathways that the kidney is involved in. So if you have kidney disease, that could be something that causes secondary hypertension. Thyroid disease, specifically hyperthyroidism, can cause secondary hypertension. Cushing's, again, something related to the kidney because of the adrenal glands. If you have too much cortisol coming, that can affect your blood pressure. Sleep apnea may be the one that is often forgotten, but could be something that is very easy to correct. A heart defect and a pheochromocytoma. What is the workup? If you are suspicious of secondary hypertension, you may want to do the standard workup of running a CBC, a CMP, a TSH, get an ECG, a urinalysis, kidney ultrasound, and a cortisol. The cortisol obviously would look for Cushing's. A kidney ultrasound could be looking for some sort of a growth or problem with the kidneys. You can also get the Doppler flow there to make sure that there's good blood flow to the kidneys. Urinalysis can be helpful to see if there is proteinuria, which would be a sign of kidney damage. An EKG would be one way of looking at the heart to make sure that the heart is functioning well. Supposedly, if you felt like it was coming from a cardiogenic source, then you could go to an echocardiogram for the heart as well. TSH would help you rule out thyroid disease, and then the CMP is a good way of analyzing the functionality of the kidneys. Orthostatic hypotension. What is orthostatic hypotension? Orthostatic hypotension is a very common side effect of medication. It is when you are normally standing up. When you normally stand up, we'd say about half a liter to a full liter of blood is going to go to the legs, which is quite a bit when you think about that. If the body cannot manage that dramatic shift rapidly enough, it's going to result in orthostatic hypotension. What are the causes? So this is something that you really want to think through. What are the causes of orthostatic hypotension? The causes include hypovolemia. Hypovolemia, number one cause of that would be dehydration. The other major cause of orthostatic hypotension would be drugs, thinking side effects. And you could go through an entire list, basically every medication that is prescribed in a psychiatric sense, and the treatments of hypertension will all cause or could potentially cause orthostatic hypotension. It also could be autonomic dysfunction. Hypotension without an increase in heart rate to compensate would be a big sign for that. So the workup of orthostatic hypotension may involve something like an EKG, a CMP, a TSH, a glucose, and tilt table testing. And remember, if there was hypotension that occurred and no shift in the heart rate to compensate, that would make you think of what type of orthostatic hypotension? It would be an autonomic dysfunction. The treatment of orthostatic hypotension will be to get down to the root cause. If it is hypovolemia, then obviously getting fluids back in you will solve the problem. If the problem is related to drugs, then we need to stop the offending agent. Compression socks could be something that would be helpful. And if it is an autonomic dysfunction, I'm assuming if you are in a family practice facility, you may not know exactly what they do to treat that, so you would probably refer them to a neurologist. Fludrocortisone can treat if it is just a long-standing thing. I know that I've run into a lot of people that have a condition called POTS, and POTS can affect things like orthostatic hypotension. So if it is a benign cause but a chronic condition that someone is having, they may take something like fludrocortisone that can help them retain sodium, and that would be 0.1 milligrams PO, and that is orthostatic hypotension. Next, we have cardiogenic shock. What is cardiogenic shock? Cardiogenic shock is decreased cardiac output. This is generally resulting in hypoxia. What is the result of this decreased cardiac output? Well, if you think through it, if you have a decrease in cardiac output, it's going to affect how much blood supply is reaching tissues, especially the essential tissues, the brain, the heart, the lungs. So if you have a substantial decrease in the cardiac output, it can cause tissue hypoxia. The tissues are not receiving oxygen, and that's why we call it shock. There's multiple reasons why someone can go into shock, and it's generally a result of decreased cardiac output resulting in tissue hypoxia. The thing that you want to think of in the relation of cardiogenic shock is coronary artery disease would lead to, in a worst case scenario, what? Coronary artery disease is that risk factor for a myocardial infarction or heart attack, and that can end up killing you. Myocardial infarctions can lead to cardiogenic shock. If you think about it, if you have that blockage in the vessel, you're going to go into cardiogenic shock, and cardiogenic shock leads to 70 to 90% of death. So this is where it's really tricky whenever people are saying that this is the number one cause of death. They usually start with something very broad and vague that encompasses multiple things, and then you also, as you get to the specifics, they also are included in that tally mark of death. So what are the signs and symptoms that someone is going into cardiac shock? Well, if you think about its correlation with a myocardial infarction, then one of the main symptoms of cardiogenic shock is going to be the symptoms of myocardial infarction. These symptoms include what? So I want you to say them in your head. Symptoms, signs and symptoms of a myocardial infarction, which are also signs and symptoms of cardiogenic shock, are chest pain, sweating, dyspnea, palpitations. There is a specific sign. That sign is when someone puts their hand over their heart because of the pain. What is the name of that sign? The name of that sign is Levine's sign. Another sign and symptom of cardiogenic shock or myocardial infarction symptoms would be dyspnea on exertion. Myocardial infarction leads to cardiogenic shock, which leads to hypotension, cyanosis, ashen pale, cool skin, rapid or faint pulses. So those would be the more specific symptoms of cardiogenic shock. So again, what are those specific signs that someone has, that this has built to a point where they're having cardiogenic shock? Their blood pressure has dropped dramatically. They're not getting the perfusion that they need. They're showing signs of that in their face and that they're either pale or cyanotic. Their skin is cool and they have these rapid faint pulses. Those are the general signs of shock. What is the workup? If you believe it is cardiogenic shock, then the workup is going to be the same workup as you would do for a myocardial infarction. We'll get to that later, but we'll probably hit it multiple times. So what is the general workup for a myocardial infarction? Some of the first things that are done would be to get an ECG or an EKG. I'll go back and forth on saying that because sometimes I say ECG, sometimes EKG, tomato, tomato. Troponin, creatine kinase, myoglobin, LDH. You may get an echocardiogram. And then generally, in the more broad term workup, in the blood work, you may also gather a CBC, a CMP, and a BNP. What is the management of cardiogenic shock? Maintain fluids, maintain blood pressure and cardiac output, and a lot of this may be that you're running the advanced cardiac life support protocols. We'll go into more depth on that when we get to myocardial infarction. So a myocardial infarction is also known as heart attack. It is estimated that there are about 1.5 million people who have heart attacks every year. And the primary definition of a heart attack is going to be that coronary artery disease, and that is affecting the arteries. So you have that blockage in the arteries. What puts people at risk? The number one risk factor for a myocardial infarction is going to be atherosclerosis. We find that atherosclerosis is present in about 90% of cases. And 90% of cases, that is the cause, we would say, of the heart attack. So atherosclerosis, that buildup of lipids in the vessel walls of the coronary arteries. What are the signs and symptoms of a myocardial infarction? In practice, generally, anytime someone presents with chest pain, it is now your obligation to rule out that they are not having a life-ending problem, a life-ending disease such as a heart attack. It is our obligation to make sure that they do not have a heart attack whenever somebody presents, especially if it is an adult, with chest pain. The chest pain tends to be, it is usually unremitting, 30 to 60 minutes. One of the classic signs is that it is radiating pain. Sometimes people describe it as chest pressure. What people in general have unusual presentations of myocardial infarction? Sometimes, I believe women were on that list, but elderly people and diabetics often have more obscure presentations of a myocardial infarction. Sweating with the chest pain, tachycardia, lightheaded, shortness of breath, nausea, and cough. And remember that sign, the Levine sign, is also one of the things you can look at as far as symptoms, signs and symptoms of a heart attack. In general, because of the conservatism related to medicine, especially if you were in an emergency room setting, anytime someone presents with a chest pain, they will be getting the standard workup. This standard workup is an EKG. And what is it that you are looking for on an EKG? What is the diagnostic sign on an EKG of a myocardial infarction? The diagnostic sign on an EKG would be ST elevations in contiguous leads. And those are leads that are next to each other, because the leads on an EKG are basically a map of some of the electrical activity of the heart. And so it needs to be in contiguous leads. We'll find later, if you want to ask yourself this now, if you had ST elevations in every lead, what would be the name of that condition? So you can answer that now. We'll come back to that in the future. The workup is an EKG, cardiac enzymes. The best cardiac enzyme, the one that we use and emphasize the most, is which cardiac enzyme? That is troponin. The thing about a troponin, though, is it is released at 3 hours. So the key in an emergency room setting is you run the troponin. If the troponin is negative, they still may be having a heart attack. If the troponin is negative, you keep the individual under observation, and 3 hours later, you run a second troponin. And that is how we would rule out a myocardial infarction, is repeat troponins. However, the other cardiac enzymes are also useful. Those other cardiac enzymes are the creatine kinase, CKMB. So the cardiac enzymes are useful as well because they may be telling you signs and symptoms of a past heart attack. Because the creatine kinase, you'd have to look it up on your own. The creatine kinase levels will peak within about 12 to 24 hours, and then they would return to normal within 2 to 4 days. So you pull out you run the different cardiac enzymes, and then those can tell you not only if they are having a heart attack, if they've had one in the past, and how long ago it occurred. What is the treatment for a heart attack? Now, remember that you can run ACLS protocols depending on how the patient is presenting. The treatment is the thing that I always remembered was MONA-B. MONA-B. MONA, the M, stands for morphine. You're wanting to control the pain. The O in MONA stands for oxygen. You want to make sure the patient has oxygen. N stands for nitrates. A stands for aspirin. The dose of aspirin would be 162 to 365 milligrams. And B is a beta blocker. The beta blocker that is preferred would be what? The one that is preferred would be metoprolol, 50 to 100 milligrams. So that is MONA-B. The dose of the nitrate would be 0.4 milligrams sublingual. So that is the initial treatment to help manage the symptoms. The problem is they have the blockage in the heart, and it depends on what that blockage is. So the treatment may include thrombolysis if the blockage is due to thrombosis, streptokinase, urokinase, redoplase. Those are drugs that are used to break apart the clot. You could also use a percutaneous coronary intervention or angioplasty, where they will go through and they will open up the vessel more mechanically, and they will put a stent in its place. So that is what myocardial infarction is. One of the things that they also wanted you to know that's somewhat related to a myocardial infarction that may mask one. This is not a myocardial infarction, but it may be similar to it. What they are looking at here is something called Prinzmetal angina. What is Prinzmetal angina? Prinzmetal angina is basically a coronary artery vasospasm. This vasospasm can lead to a myocardial infarction or even sudden death. So you think about this vessel, it just spasms. We may not know the full cause of it. The EKG may be showing transient ST elevations. The age range, it's a variable age range. The average is around 50 years old. Signs and symptoms would be chest pain. Basically, they're presenting identical to a myocardial infarction. They can have that radiating chest pain, that chest pressure, the diaphoresis, the Levine signs. And here's the big problem is there is no specific sign and symptoms. The myocardial infarction, the workup is going to be the same because they presented with chest pain, so you are running your standard protocols for chest pain, which include EKG, cardiac enzyme, CMP, drug toxicology. If it was really intermittent, this pain, then you may be considering getting something like a Holter monitor. An EKG, so what would be the signs that you would think of in terms of revealing that this is Prinzmetal angina? The main things that you'd be looking for in real life or on a test would be the buzzword is the EKG is showing something. The EKG is showing transient ST elevations that come and go. The ultimate diagnosis of this would be made on a coronary artery angiogram. What you would see on that would be there is not this atherosclerotic blockage of the heart. Rather, you can see that the vessel basically looks normal. It just has undergone a vasospasm. The treatment would be nitrates and calcium channel blockers. Another thing that was listed is a NSTEMI. The N stands for a non, so this is a non-ST elevation myocardial infarction. We have said that there are myocardial infarctions that are STEMI, so it is possible to have a heart attack without the ST elevations. And the reason why this is significant, because it means that perhaps we don't put all of the emphasis or diagnostic on an EKG alone. The EKG is not 100%. No test that we have in medicine is 100% accurate. So the way that this is diagnosed, it's very logical if you think through this. Basically, the diagnosis of a NSTEMI is going to be that they have a normal EKG, but you have run the cardiac enzymes, and the cardiac enzymes are revealing that there is a heart attack. What I have written on this is that this is the duration. These are somewhat the hours in which the levels peak. And troponin is 3 to 8 hours. Myoglobin is even shorter, and that is 1 to 3 hours. But the troponin is the most sensitive of them all. So the reason why I believe that is being emphasized is an EKG is not 100%, and the enzymes are a little bit more accurate. In an article that I pulled up, this is from the Journal of Emergency Medical Services. They put that an initial 12-lead EKG has a sensitivity of about 68% for diagnosing an ST elevation myocardial infarction. On the flip side, it's about 97% specific, meaning that if you see ST elevations, there's really about a 3% chance that... Delete one of those last parts, because this is the essence of it. That specificity means that there is a 3% chance that if they have those ST elevations that they are not having a myocardial infarction. Whereas the troponin sensitivity is about 95%. So that is still the gold standard for the diagnosis of a myocardial infarction. So if we have ruled out a heart attack and the patient is still having chest pain, we call that angina. Angina can be categorized as stable and unstable. What is the main difference between stable and unstable? The primary differentiation that we make between stable and unstable angina is going to be whether the chest pain is relieved by rest or nitrates. So, if an individual is not having their chest pain relieved, then they have unstable angina. However, if their chest pain does relieve when they rest, when they sit down and relax, or take their nitroglycerin, then that's going to be categorized as stable angina. And that would be, typically, the symptoms would be relieved in about 1 to 5 minutes of rest. The signs and symptoms of angina, the definition is in of itself chest pain. The signs and symptoms I listed on the flashcard are chest pain, pain with exertion, chest pain eating in the cold with stress. The pain usually doesn't change with respiration, cough, or position. The workup for angina is generally done previously. The first time a new onset of chest pain means you're going to run through all of the cardiac enzymes and EKG, and you're going to get to the bottom of it. Once you have ruled out that cardiac pathology, you say, you have this blockage. So the treatment is going to be basically what we do to treat coronary artery disease, because coronary artery disease is basically what you're saying this angina is. You have coronary artery disease, so change in your diet and exercise will be helpful. But the main thing we need to do is we need to make sure that your cholesterol is under control. What are the levels of cholesterol that we are aiming for with treatment? If they are at an extreme risk, it is recommended to have an LDL of less than 55. Someone who has a high risk due to their coronary artery disease, it is recommended to have the LDL less than 70. Someone who is at a moderate risk would be less than 100, and someone who is at a low risk, that LDL is recommended to be less than 130. So controlling cholesterol, diet, and exercise, controlling the hypertension. Controlling hypertension would be, again, looking at the hypertensive medications, ACEs, ARBs, beta blockers, calcium channel blockers, and diuretics. The other thing that is recommended, so we mentioned the treatment, you want to make sure diet, exercise, cholesterol, blood pressure, and then the other thing that's recommended for people who have a cardiac risk would be what medication? That would be aspirin, 81 to 162 milligrams daily. What is the dose of nitroglycerin that is used? The dose of nitroglycerin is 0.4 milligrams sublingual. So in a clinical setting, what's usually done is you have the general workup that's done, and then the patient has this, they know that their chest pain is not a heart attack, so you've been able to differentiate between this chest pain is going to kill me and this chest pain is not. And then you say whatever you're experiencing is now your new baseline. And if it ever gets worse or changes, then we need to repeat the entire cardiac workup. Do another repeat EKG, troponin, repeat troponin to rule out a myocardial infarction, because these people are very high risk. So someone who has unstable angina means that they do have chest pain at rest. It's more frequent, it's more severe, it's prolonged, and it's changing, and it's not responding to nitroglycerin. So basically, these individuals will need to be hospitalized, and you're going to need to do what? You're going to have to go back and do that whole workup. Aspirin, metoprolol, nitrates, clopidogrel if someone can't do aspirin. So if you think about it, if someone has, the reason why we have unstable angina here is because if someone has unstable angina and they have chest pain that is not relieved with rest, they're going to need to go to the emergency room. The emergency room will do a full analysis, and perhaps they're not having a heart attack, but the blockage is significant enough that it's giving them these symptoms, and so they will go through, and the cardiologist is going to do a workup and a treatment, and probably work to find out where the major points of blockage are, and even though they're not currently having a heart attack, do a prophylactic treatment, which would be to maybe put a stent in some of the vessels that are mostly blocked, and that's likely what is used. So these are all good opportunities to review this, because it's something that is hammered in quite a bit with medications. Again, if somebody cannot take aspirin, what would you give them? Clopidogrel. What is the treatment of a myocardial infarction initially in the hospital? Remember, Mona B, morphine, oxygen, nitroglycerin, aspirin, and a beta blocker. I know a lot of the times when it comes to the use of nitroglycerin, sometimes they will say not just after one dose, but you'll do one dose, and if it's not working, then you'll take a second dose, and if that's not working, then you'll go to the emergency room. What I quickly looked up is it says you would take one sublingual tablet, and then you can do that every 5 minutes, 3 times, but you don't want to take it more than 3 times. So if that were to occur, that would be an indication to go and get a workup through an emergency room. So we're going to change directions, and the next thing we have is systolic heart failure. What is systolic heart failure? Systolic heart failure is a clinical syndrome associated with congestive symptoms. It's related, so this is the key part, it is related to impaired ventricular pump function. In other words, systolic heart failure, think of systolic, that is the contraction of the heart. Heart failure, it doesn't mean that it's completely failed, it's more like it is failing, or that there is failure in the heart, in the systolic capacity of the heart. So it's this syndrome that is the heart is unable to pump as hard as it needs to. So it's going to affect the overall ability of the heart to generate a sufficient cardiac output. Some of the buzzwords associated with this would be what? If you ran an ultrasound, what sign would you see on an ultrasound that would be an indication of systolic heart failure? That would be B lines. B lines on an ultrasound are indicative of a systolic heart failure. The major definition of systolic heart failure is going to be determined by this, an ejection fraction. So the ejection fraction is how we assess systolic heart failure, and the definition of systolic heart failure is when the ejection fraction reaches what? The ejection fraction reaching less than 45% is systolic heart failure. The guidelines on this have been established by the New York Heart Association. What are the signs and symptoms of systolic heart failure? This used to generally be described as congestive heart failure, but so that if you remember that terminology better, you can now just copy-paste that under systolic heart failure. So if the heart is not able to produce enough cardiac output and the ejection fraction has decreased lower than 75, you can expect to see JVD, rales. The individual, because they have this fluid buildup in their lungs, may have a nocturnal cough and ankle edema. Basically, because the heart isn't able to pump as much, things are backing up. And the backup is going to show, for the most part, in the lungs and in the legs. Ankle edema, nocturnal cough, JVD, jugular venous distension, rales. So the New York Heart Association has class 1, which would be asymptomatic, meaning we've gone through a workup, we found that the individual has a decreased ejection fraction, and perhaps that when it says asymptomatic, that you're not seeing as much related to things like the JVD, the rales, the ankle edema, or the nocturnal cough. So class 2 is going to be symptomatic, generally with physical activity. Class 3 would be symptomatic on less than ordinary activity. That could be even things like being out in the cold, eating in particular. And class 4 would be symptomatic at rest, meaning that even when the individual is doing nothing, they may be coughing because of the buildup in their lungs. They may also have that ankle edema, that can be pitting edema, that is a buildup. And these are, again, the signs of that ejection fraction decrease or decline in the ejection fraction. The workup of a systolic heart failure, or which used to be congestive heart failure, the primary thing that you need to remember on the workup that can be diagnostic would be a BNP, the beta-natriapeptide. I guess the main diagnostic thing is going to be the echocardiogram, because it's through an echocardiogram that you're able to assess ejection fraction. These individuals generally have an exercise treadmill test, and that can help in the assessment. CBC, lipids, BNP. So those are some of the workups that you do with someone that you're concerned about systolic heart failure. Usually these patients may be presenting with things like dyspnea, ankle edema, this long-standing cough, a chronic cough. These individuals, you may run a BNP, and once you get the BNP, you may send them to get an echo and refer to cardiologists to get the exercise treadmill test. It may evolve something more like that in a clinical setting. What is the treatment? The treatment is to control the risk factors, smoking, diabetes, and alcohol. The reason why they may have systolic heart failure, this is something that I didn't put on my flashcards, but it helps you understand this. Why would somebody have systolic heart failure? The most common are going to be the fact that they're old. The heart may just be slowly giving out because we are not immortal. We eventually age, and part of the aging is the heart, its ability to pump declines with age. But the other significant one that you want to remember is going to be a myocardial infarction. The myocardial infarction, because of the hypoxemia and the tissue damage that occurs, the whole entire heart might not be dead, but part of it may have suffered greatly, and as a result of that, their ejection fraction declines. So you can put in a stent and keep them safe by opening up the vessel, but there still can be damage to the heart, and their ejection fraction could be compromised as a result, so they will have these chronic symptoms of edema and the congestive heart failure. The treatment, again, control those risk factors. If they have ankle edema, you'll be treating that with what medication? Diuretics. Diuretics are used to treat the symptoms of systolic heart failure, and that would be things such as furosemide. We would also use things like ACEs and ARBs, beta blockers, and digoxin. Digoxin is particularly important because digoxin works by what? Digoxin is the medication that works by increasing the ejection fraction, and that is a unique thing that digoxin does. The other thing that we have listed is diastolic heart failure. So systolic is the body's ability to pump. The diastolic heart failure means the left ventricle does not fill. It is stiff. It is a stiff left ventricle. It is not filling. Its capacity has been limited. So this is kind of similar to what you may see with one of the problems that you may encounter with a valve, like a aortic stenosis. If the valves become stiff and are built up of calcium, and so the valves make it so just less of the blood is able to actually make it into the ventricles, so that they're not filling appropriately. So this is again, remember, the left ventricle isn't filling. So this is a problem in the filling capacity. So the reason I pointed out the aortic stenosis, because it kind of helps give you that image. And as a result of that, they may be having the same types of symptoms. So take a moment and list those in your head. What are the symptoms that you would see associated with heart failure? It is the backup. So you're going to have backup of the blood that's going to fill inside the lungs, which can cause rales. It will also have buildup in the feet, which can cause edema. The thing that I forgot to mention included with the rales is the chronic cough. And then it can also have buildup that is recognized by jugular venous distension. So this is heart failure. So the definition, if you remember, the definition of systolic heart failure is what? That definition was the ejection fraction less than 45%. So say someone has symptoms of heart failure, but their ejection fraction is normal. That is where you're going to be thinking of a diastolic heart failure. Heart failure, even though the ejection fraction is normal, and that is going to be indicative of diastolic heart failure. The diagnosis ultimately, the same with systolic heart failure, is going to be made by doing what? Doppler echo. So an echocardiogram is going to make this diagnosis, and it's Doppler because you have to look and evaluate the movement of the blood flow. Signs and symptoms, remember, would be shortness with breath, chronic cough, dyspnea on exertion, fatigue, weakness, and edema. What is the treatment? Remember, diuretic therapy, something like furosemide, to help reduce the pulmonary congestion as well as the congestion in the feet. Another thing that can be used to help treat the congestive buildup in the feet would be compression socks. Patients may need a beta blocker, and then ACEs and ARBs. And if you remember trying to identify the specific cause, these patients generally are going to be referred to a cardiologist, and they can give them the more specific information and treatments, whether they are surgical treatments available. In a family practice setting, your job is going to be predominantly managing the diabetes, helping them quit smoking, making sure that they're taking lipids and antihypertensive medications. Okay, we're going to be going through, at this point, some of the EKG findings. So just as a quick review, if someone has ST elevations, and you're seeing these ST elevations in contiguous leads, that would be indicative of a myocardial infarction. If someone has a ribbon-like appearance on an EKG, that would be indicative of torsade de pointe. If you're seeing a rhythm that has a lot of up and down with the heart rate greater than 100 beats per minute, when you're seeing this just up and down, but it's consistent, not like the consistency that you would see with an atrial flutter, it's going to be an indication of ventricular tachycardia. 100 beats per minute with 3 irregular beats in a row. This is a definition of VTAC. Torsade de pointe is going to be the ribbon-like appearance. If someone just has an extreme bradycardia, So these huge spans in between the PQRST intervals, that could be an indication of sick sinus syndrome. If the individual has this very scribbly look on an EKG, it's hard to describe these off the top of my head. So the scribbly look on an EKG is going to be a ventricular fibrillation. So we'll go over each and every one of these individually. I just want to review some of the EKG quickly on these. If an individual has a prolonged P to Q interval, a prolonged P to Q interval would be an indication of a first-degree block, a first-degree atrioventricular block. If an individual had bunny ears in V1 and a wide QRS in V6, so bunny ears in V1 would be indicative of a bundle branch block, a right bundle branch block. So the right is important to remember because the right is in V1. If an individual has complete dissociation between P's and Q's, if a person has complete dissociation between P waves and Q wave in a Q, that would be indicative of a third-degree AV block. If going back to that VTAC description, since I somewhat botched it, in something like AFib, you're going to see the P wave, and the P wave is basically having no correlation with the QRST interval, and that's the indication of AFib, because AFib, it's just these P waves are just kind of going, and they're going at a irregularly irregular phase. So irregularly irregular P waves would be indicative of AFib, whereas ventricular fibrillation, it's consistent, the heart rate is consistent, but it's like that QRST, which is a more sharp length, and that's just going up and down, up and down, up and down, and that is your VFib. If there are more P waves than QRSs, so there is some dissociation between the P's and the Q's, then that is going to be a second-degree AV block number 2. What is the name for a second-degree AV block number 1? That is a Wenckebach. The Wenckebach is where you're starting to see some dissociation, where it will be a P to Q, it just slowly gets longer and longer and longer until one skips. If an individual had bunny ears in V6 and a wide QRS in lead 1, but the bunnies are in V6, then you have a left bundle branch block. If you were to see a sawtooth appearance on an EKG, you would be thinking of atrial flutter. Again, AFib is defined as irregularly irregular. So let's run through these one at a time and go into a little bit more depth on the different things that you need to know on an EKG. So let's start with ventricular tachycardia. Ventricular tachycardia is responsible for most sudden deaths. They estimate about 300,000 per year. The description, how would you describe VTAC on an EKG? VTAC is going to be that up and down, up and down, up and down, not so much sawtooth as you would see with an atrial flutter, because it's a bit more aggressive. It was described as rapid, monomorphic, 200, sometimes it can go up to 280 beats per minute. Ventricular tachycardia is any rhythm faster than 100 to 120 beats with 3 irregular beats in a row. The signs and symptoms of this: palpitations, lightheaded, syncope, chest pain, and may be asymptomatic. So again, these patients are in great distress. The chest pain, you would be getting the EKG because that's what we do in the general workup. But this is also something that if somebody were to develop syncope, lightheadedness, palpitations, that would be an indication to get the EKG. And if you were to see this appearance, then you know that they have ventricular tachycardia. One of the great risk factors for VTAC is going to be that they have had a prior myocardial infarction. You're going to do an EKG and run your ACLS protocols. the EKG, as part of the ACLS protocols, you're going to get blood work. Included in the blood work will be what? You're going to get your cardiac enzymes, a CMP, and a toxicology. You want to see if this could be drug-induced. The CMP will be telling you their calcium level, their potassium and magnesium level. The treatment. So according to the ACLS protocols at this time, it is synchronized direct cardioversion, 100 joules monophasic. Synchronized direct cardioversion, 100 joules monophasic. Unstable would mean that it is, if the patient is truly unstable, you're going to go to immediate defibrillation. If the patient is stable, then you can actually do 100 joules monophasic cardioversion, and that is ventricular tachycardia. The next one is VFib. Remember, how would you describe VFib? VFib looks like scribbles. This is the most common arrhythmia in cardiac arrest. It usually lasts for about 5 minutes before the individual goes into asystole, which is where there is no more action and they're basically dead. So you have this 5 minutes. It's kind of like your heart's last dying and screaming for breath. 65 to 85% of people will have, with cardiac arrest, have ventricular fibrillation. This will usually end in death within 10 minutes. Signs and symptoms of cardiac arrest: the patient may go unconscious immediately. This is the person that has fallen to the ground, that is having this heart attack. It looks like they've just suddenly died, and as a result of this, you're going to make sure that you're running BLS and ACLS life protocols, and those would be, obviously, you're going to be doing CPR, trying to get the person ready, make sure that we get a defibrillator. The ACLS protocols are going to be CPR, defibrillation, percutaneous coronary intervention, implanted cardioverter defibrillator. Remember the whole workup that we've described, and I'm going to keep going over this so it helps stick in your brain. The workup in an emergency room, make sure that they get hooked up to a 12-lead EKG. You're going to be getting IV access so that you can give them fluids, make sure they have oxygen. The individual is going to be getting blood work done, calcium, potassium, magnesium, CBC, CMP, arterial blood gases, drug toxicology, cardiac enzymes. So you're doing, basically running this whole gamut of tests, and also doing the protocols to make sure what this person, obviously, if they have this ventricular fibrillation, you're going to be prepping them for defibrillation. If they had VTAC, you're going to be doing the synchronized direct cardioversion, 100 joules monophasic. And if they fall into VTAC and become completely unstable, that's when you're going to be doing defibrillation. All right, next I have torsade de pointe. Torsade de pointe is going to be that ribbon-like appearance on an EKG. The main thing that you need to remember that's associated with this is going to be what? The main association, the main buzzword is going to be magnesium. The risk is hypomagnesium. Low magnesium can cause this. It's going to affect the ability of your heart to function, and it can result in torsade de pointe, this ribbon-like. And so the treatment is going to be magnesium, IV magnesium, 1 to 2 grams IV. These patients obviously are hospitalized. They generally present to the ER because there's signs and symptoms that they have. The patient presents, say that magic word, chest pain. And what are you going to do with someone who has chest pain? Get the EKG. The EKG will be able to rule this in or out. If you see this in there, then this patient is going to the emergency room. You're going to try and get IV access and start them with magnesium, 1 to 2 grams IV. And repeat every 15 minutes. The patient may need cardioversion if necessary. Some of the risk factors for this would be congenital long-term long QT intervals. What things increase the QT interval? Quinidine, amiodarone, procainamide, and lithium. I work in psychiatry currently, and you're going to see citalopram and Lexapro. Mostly citalopram or Celexa is annoying, and I try not to use it because it has something that can prolong the QT interval. A lot of the antipsychotics will do this as well, and a lot of the psychiatric medications. They just keep adding and adding, and you have too many medications that will lengthen the QT interval, then that puts you at risk for torsade de pointe. But again, the main thing you need to remember with torsade de pointe is going to be hypomagnesium. The patient may also, so we've mentioned magnesium, but there is another electrolyte that is important in torsade de pointe, and that is not calcium, it's potassium levels. So hypokalemia and hypomagnesium. So magnesium sulfate, continuous 3 to 10 milligrams per minute is what it said in one of my previous flashcards. Propranolol, long-term, they may need pacing. So that's something that a cardiologist is going to be sorting out after their emergency room visit and their hospitalization. If an individual has extreme bradycardia, you may be thinking of sick sinus syndrome. This is also known as sinus node dysfunction. This generally happens among who? So the major risk factor associated with sick sinus syndrome is going to be people who are very old. 73 to 76. This condition is due to dysfunction of the sinoatrial node. So they have extreme bradycardia, severe bradycardia, lack of P waves due to a lack of atrial activity. So it may be that you're not even seeing a P wave because the atria is doing nothing, and so the pacemaker cells that are found in the ventricles of the heart are basically keeping the rhythm, but those depolarize way slower than the atrial pacemaker cells. So the treatment of this, if you think about it, well, if an individual is in extreme bradycardia and they're not having the pacemaker cells for the atrium actually function, then this is probably going to be treated with a pacemaker. Atropine, when you see this, atropine 0.04 milligrams, sorry about that. Atropine 0.4 milligrams per kilogram IV, and this patient obviously will, in the emergency room setting, is going to be then handed in the care of a cardiologist, and that cardiologist is likely going to be doing a pacemaker. So that is your treatment of sick sinus syndrome. The patient would present, remember this is typically going to be someone who's very old, and they're going to say, I'm lightheaded, I'm dizzy, I feel like I'm going to pass out. And they said that magic word, I feel like I'm going to pass out. And you said, oh, I should probably get an EKG. And then that EKG shows this mess where they have basically no P waves and they're severely bradycardic. You're then going to remember, okay, I need to do atropine to stimulate this, and we're going to send them to the emergency room where they can get the treatment that they need, and ultimately that will be a pacemaker. On to some of the other blocks. So a first-degree block. These are the atrioventricular blocks. There are 4 that you need to remember. They are a first-degree AV block, a second-degree type 1, a second-degree type 2, and a third-degree AV block. So your definitions of these, so I'm going to mix them around. Well, no, we'll just go in order. So a first-degree AV block on a EKG is what? They have a prolonged P to Q interval. This is greater than 0.02. First-degree AV block. A second-degree AV block, type 1, its fancy name, we'll come back to that, but the second-degree AV block type 1 is going to be defined as a P to Q interval that just slowly gets longer and longer and longer until a QRS is skipped. So something skips. And if you're seeing that slowly increasing P to Q interval that skips, it will be known as a Wenke block. A second-degree AV block type 2 is where you're going to see more P waves than QRSs. You're seeing that dissociation occur between the P waves and the QRS interval. A third-degree AV block is where there is complete dissociation of P's to the QRSs. So that's your definition of a third-degree AV block. So it would be like a P QRST, then a P that's kind of masked inside the T wave, and then a P wave, and then another P wave, and then a QRST just goes on its own, and then a P wave. And so it's going to start to mess things up. But if you just see and you're looking at it, you say, well, the P's just seem to be completely dissociated. But the thing that separates this from atrial fibrillation would be what? Because AFib is going to be irregular. it's fibrillating. So the atria is going at more of an irregular rate. In third-degree AV block, the P is actually going to be more consistent. So you can see the P is consistent, but it's just not firing off into a QRS. So that is a third-degree AV block. What is the treatment? Transcutaneous pacing in the emergency room for the extreme bradycardia that may be occurring, because the P waves, similar to the sick sinus syndrome, are not triggering the QRS, and the QRS is indicative of the actual major pumping systolic effort of the heart. And so there is this bradycardia that develops in a third degree, and so you may need to be pacing them in an emergency room setting. The atropine can be used, and again, these patients will usually be presenting with syncope, dizziness, and they are going to need that EKG, and the EKG is going to be your way to diagnose those AV blocks. Another type of block that we can see is going to be a bundle branch block. So if the bunnies are in number 1, then think of right. A lot of times we think of right as first and left as second, because most people are right-handed. So if the bunnies are right, then this is bunny ears are in 1, then that's right. That's a right bundle branch block. If the bunnies are in the 6th lead in V6, then that is a left bundle branch block. The other thing associated with that is a prolonged QRS interval, and the QRS is going to be inverted. So if the bunny ears are in V1, then the wide QRS is going to be in V6. And if the bunnies are in V6, then the QRS is going to be in V1. So that's how you differentiate between a right bundle branch block and a left bundle branch block. Left bundle branch block, cardiac conduction anomaly. It is seen on an EKG, delayed ventricle contraction, very wide QRS, 120 ms in V1, R wave, M shape in V6, bunny ears in V6. Refer to a cardiologist, they may need a pacemaker. A right bundle branch block is a cardiac conduction anomaly diagnosed on an EKG. You have the wide QRS in V6 and bunny ears in V1. This may require a pacemaker. So that is the information that I have on the bundle branch blocks. Moving on, if you were to look at an EKG and you would see something that looked irregularly irregular is going to be your sign that this person has atrial fibrillation. There is no P wave. The atrial activity is so rapid sometimes that you can't even see that on there. So it's almost like there's this fibrillation going on in the background, and then you have these QRSs that are just kind of coming and going, because occasionally the P wave may trigger the QRS, and so it's very irregularly and irregular. Signs and symptoms. The signs and symptoms of this are going to be very wide range, but think about most of the things that we've been talking about. The patient feels a sense of palpitations. They may be very tired. They may have lightheadedness. They may have syncope. They may pass out. They may have dyspnea on exertion, fatigue, even the chest pain. So any one of those symptoms, in general in medicine, when a person presents with chest pain or they present with syncope and lightheadedness, you're going to get an EKG. And if you do that, you're going to be able to evaluate the EKG and try and rule out some of these very significant conditions that we've been going over. So that's how it pertains in a clinical setting. Just remember, patient says syncope, EKG. Patient says I'm dizzy all the time, get an EKG. Patient says chest pain, get an EKG. Do that 100% of the time, and you're probably going to be just right, because that 1% of the time where it's not relevant, it's probably worth just getting it just to be safe, because that's how medicine is. We are very conservative. So the risk, 12 to 25% of strokes are related to atrial fibrillation. We assess the risk with a what? So there is a scoring system that helps you assess the risk of atrial fibrillation. That risk is assessed through a CHADS-VASc score. The treatment, you can treat this by doing in an acute setting, cardioversion, 120 to 200 joules cardioversion. IV amiodarone could also be used. The dosage of IV amiodarone that is used to treat atrial fibrillation is 150 milligrams IV. Rhythm control, so they may take amiodarone daily. 600 milligrams daily would be more for a chronic atrial fibrillation. they may need cardioablation. So that would be that ablation would be performed by a cardiologist. Because these patients are at a significant risk for stroke, then these patients are going to be treated not just with amiodarone to help stabilize the cardiac anomaly and the irregular pattern of the electrical conduction within the heart. These patients are also going to need anticoagulants. So, I mean, really, if they don't have any risk factors, what was written down is they really don't need any anticoagulation medication. But if they have one risk factor, then they're going to need aspirin, 81 milligrams to 325 milligrams. If they have two risk factors, they may need a more significant anticoagulant, such as warfarin, which tends to be the most commonly used one. But there are other ones. Warfarin is just the most common. So that would be an example of how people are treated with their AFib. So in a larger scale thing, this patient may need cardioablation and then a pacemaker set in to correct the anomaly. But sometimes they don't go through that whole process. They'll say, well, we can maybe just manage this without the surgery and just do amiodarone and then manage the risk factors. So that would be atrial fibrillation. Atrial flutter. Atrial flutter is characterized by what on an EKG? This is a sawtooth. So as opposed to ventricular tachycardia, where it's kind of just up and down, up and down, up and down in a very consistent way, this is sawtooth because you're seeing a very up and down from the P waves, but then it's broken up by these consistent and regular QRS intervals. Whereas you don't really see much of a P wave on a VTach because everything's just swallowed up by the ventricular tachycardia. That QRS is so powerful that you don't even see P waves and it's just up and down. Whereas this, you're going to see a differentiation in size from the up and down consistent sawtooth appearance from the P waves as opposed to the QRS. So again, that's indicative of the fact that the atria are going out of control. The signs and symptoms are what? Well, it's basically everything that we said multiple times in a row. The patient presents and says, I'm really dizzy and I just don't know why. Get an EKG. Or this patient has passed out, or they have been passing out. Get an EKG. Or they say that magic word of chest pain, get the EKG. Heart rate is usually very rapid. So that could be another thing that would indicate this. So someone who has an extreme tachycardia that's been going on for a long time, this individual needs an EKG. The heart rate is usually greater than 150 beats per minute. The diagnosis is made on an EKG. It may also be made on a Holter monitor or an exercise treadmill test. The treatment. How do you treat atrial flutter? The treatment is adenosine or IV calcium channel blockers in an acute setting. In a more prolonged setting, this patient may need a pacemaker. I do believe that cardioversion can also be used in an acute setting to try and get this to go back into a normal thing. But if obviously it's something that's going on more chronically, then the individual is going to need a pacemaker. The last two things that we have that are related to these dysarrhythmias are going to be premature atrial and ventricular contraction and paroxysmal supraventricular tachycardia. So the first is a premature atrial and ventricular contraction. This is generally found when? Well, the patient presents with chest pain, and what happened is you did the whole workup of that, and you said you do not have a heart attack. Well, they said, my chest pain, it still comes and goes. What's going on? And you say, we don't know. We just know it's not a heart attack or something that's going to kill you immediately. Or the individual may have presented and said, I just feel like my chest flutters every once in a while. I never have chest pain. This individual does not have any risk factors. You probably still got an EKG and said, okay, that looked normal. But because you're not having symptoms right now, let's get you a Holter monitor. And on that Holter monitor, you're going to be able to pick up things. So this is a finding that's often found on a Holter monitor. Observation is the treatment. Ablation if it is severe. The main thing that is going to be definitive, or main thing that is symptomatic of this, is going to be this intermittent, because it's a premature atrioventricular contraction. It's usually asymptomatic. It could be this flutter that comes and goes. Intermittent, so if they're intermittently going into these episodes where I just feel really dizzy, but it doesn't last very long, you get the EKG at that moment. You could even do the whole cardiac workup and say, okay, well, it's not a heart attack, but the problem is because you're not having symptoms now, maybe your heart's going into these phases. Let's get a Holter monitor and see what happens. And obviously, if things get very dramatically worse, you can always go to the emergency room to get that assessment. So the workup: EKG, CBC, CMP, drug toxicology, TSH, cardiac enzymes, and Holter monitor. The Holter monitor is the main thing that you're thinking about this, because the main thing you would be asking in a clinical setting is when to use a Holter monitor. And you use the Holter monitor if you're trying to pick up symptoms of things that are coming and going, especially when you've ruled out the severe cardiac pathology. The treatment is observation if it is not symptomatic. The patient may need catheter ablation if it is severe and symptomatic. But most of the time, patients may go into these, and as long as it's not changing or not getting worse, then you may just be able to observe it. Paroxysmal supraventricular tachycardia. Episodes of rapid heartbeats originating in the ventricles. Palpitations is the number one symptom. Dizziness, shortness of breath, chest pain, syncope, and fatigue. Risk. Digoxin causes this very commonly. Why is someone taking digoxin? Digoxin increases the ejection fraction. And why would you need to increase the ejection fraction? Because the ejection fraction has declined because they have systolic heart failure. And the most common cause of that systolic heart failure is they're very old or they had a previous cardiac myocardial infarction. So digoxin causes this paroxysmal supraventricular tachycardia. The workup is CBC, CMP, TSH, cardiac enzymes, EKG. If you're not sick of me saying that over and over and over again. If it's intermittent, you consider a Holter monitor. The treatment is cardioversion if the patient is unstable. 50 joules. If they are stable, then you can do vasovagal maneuvers and see if that will, and if that's not working, you can do adenosine. So paroxysmal generally means it comes and goes. So it's these episodes where it's going into these rapid heartbeats, but then it stabilizes on its own. So those are the dysarrhythmias and the first part of the cardiovascular system. And I'll have the second part 2, coming up next.